Oh my goodness. How is that for dramatic entry music? Welcome to LinkedIn live stream. I'm Kevin McAvey. I'm going to be joined here by Michael Valley and Christoph Stremekis from HCAI and the California Healthcare Foundation, respectively. And this is my first time live streaming. Many folks have been following and enjoying a lot of our LinkedIn health data posts over time. And now we're going to have a conversation that hopefully many can enjoy for days to come about California's all-payer claims database, the HPD. So I actually wanted to start off with a little bit of information about APCDs and even who I am, for those who haven't we haven't had the chance to meet before. My name is again Kevin McAvey. I'm with Manat Health. I'm a managing director, health data strategist and system leader. Work with states across the country. Health data, it's fair to say, is my life. And I actually started off 12 years ago, 15 years ago as an APCD programmer. And one thing that I felt so privileged to be part of back then and continue to feel privileged to be part of now is how our states are increasingly making health data about how our healthcare system is operating available to the public for use to better understand how we can address systemic issues in our healthcare system. APCDs are powerful analytic resources. And I'm going to actually bring up on screen a little and tell you a little bit of a story about APCDs for folks that aren't familiar with what they are. And we're gonna start this story with Dr. Chen here. APCDs are large and complex repositories of healthcare claims that encounter data for individuals receiving health insurance through most public and private sources. So you're an individual and you go to your doctor and you see your doctor for services because you hurt your arm or you need some assistance. That doctor, if they are under a fee-for-service contract in particular, submits a claim to your contracted health insurance provider, Unified Healthcare in this case. And then sometimes for some reason, a hospital charge gets listed in there. That health insurer pays based upon those claims, or if it's not paid on a fee-for-service basis, pays on another alternative payment arrangement type back to the providers. And all of that data, membership and claims data by state-specific specifications, is submitted to a state APCD. Now, there are exceptions to this, which I'll talk about in a moment. But when you think about health insurers across the state submitting this data to a common data repository, it becomes to be cleaned and compiled, normalized, linked, de-identified for analysis. It becomes a really rich and powerful data resource. And ultimately, that data can be used to create new information about a market. Again, this is another way of thinking about and looking at APCDs, payers submitting by state-specific standards up to state APCD agencies and state APCD agencies. HCAI in California takes and normalizes that data, makes it ready for use. And one of the most exciting things I want to talk about today is how California, the nation's biggest state, is making its APCD data available for use broadly across the healthcare ecosystem. What data is included in APCDs? By and large, individual market plans, small and group plans for members with member data, Medicaid fee-for-service, managed care, state and local employee health benefit plans, oftentimes Medicare Advantage and Part D plans. I would love to get Mike's perspective on whether that could be expected in the HPD data. or is off on the side or yet to come. And then there's some data that will never be included, or likely not to be included in most state APCDs. ERISA preempted self-insured plan data is one of the biggest ones that we should be aware of. Claims can provide an incredibly rich data source to understand how folks are moving throughout our healthcare system and how folks are interacting within our healthcare system with services and service providers. Claims can also provide clinical data, information about costs, including payer paid and patient paid amounts, administrative information about the individual, the provider, and often the plan, and patient demographic and geographic information to inform all sorts of analyses. State APCDs are now live across the country. When I started presenting this map 8 years ago, a number of states were not on it. It's wonderful to see how this is such a nonpartisan issue, building state health data capabilities to understand how our healthcare system is operating, with the 4 latest states to pursue an APCD, including Texas and Georgia, Indiana, and Alaska actively weighing it right now. But pursuit to implementation, California is releasing and providing public access to a data set that can be used to support a bevy of use cases, including better understanding how access to preventive care, screenings and treatments are changing over time, the prevalence of chronic conditions, the cost of care. And if you missed it, on December 16th, the HCAI news release, HPD is available for public use. And with that, I'd love to pull Mike up to the stage. And Mike Valley is a CIO for the California Department of Healthcare Access and Information. And it's really nice to see you and have this conversation for what might be my first and last live stream. But what a moment to actually have it. Congratulations on this big accomplishment.
Kevin, thanks for having me. And just let me thank you for all that you've done to champion the work of health data organizations across the country, as you shared before. And if I can, also just to the California Healthcare Foundation, such a strong partner of our department and the all-payer claims database from the very beginning. Just would not be at the point we are and have the success we've had so far without both of your support. So thank you.
Of course. Well, yeah. So I always like to think about the journey, right? To really appreciate where we are right now. And that journey kind of starts with leaders. And I know that there's a tremendous list of folks to thank when we actually think about how the HPD came to be where it is right now and publicly available. But can you talk to me a little bit about your journey? When did you start at HCAI, and how has your career evolved, and why is this has this been a priority for you and the agency?
Sure, happy to do that. And as you said, dozens of people behind the scenes, heads down, making all that you see in the public domain possible, and all the outputs and all the data possible. So tremendously grateful to all of them. I've been working in healthcare data, healthcare technology, policy, and management for almost 15 years. I started the department, spent some time elsewhere within the California Health and Human Services Agency. I'm trained as a political scientist, but fell in love with healthcare as a problem to solve, as a human condition to be improved. But I believe in evidence-based policy. And I believe in our government being responsive to communities and their needs. And then just quickly about HCAI, we're a state government agency. We've been a leader in collecting and analyzing healthcare data for nearly 50 years. So I just take great pride in being part of an organization that in candor existed before I was born, was producing healthcare data analysis before I was born, will be for many years to come. And so it's tremendously humbling to just be a part of this effort and to be a part of the team here at HCAI.
Yeah, and it takes a minute to set up an APCD, right? When was like the HPD like first introduced? And I'm assuming, I think it was like time that has a weird shape to it now through the pandemic. 5 years ago, 7 years ago, like when was it first established?
Well, the conversations have been started much earlier than that. Over a decade ago, as you know, many other states, the map you showed, have been working in this space for much longer than we have in California. So we're sort of late to the game in some ways, but the discussions amongst policymakers have been going on for some time. In 2018, we were given the authority to commission a study about how to build an APCD and how to operate it. And we're given some seed money to start then. We convened a group of stakeholders and experts, made some recommendations, again, really leveraging and standing on the shoulders of all of the organizations and states that have came before, trying to learn from them. In 2020, the legislature approved those recommendations, codified them into law, and then we were off in running. 2022, we collected the first data. In 2023, we produced our first public reports. And then, as you mentioned before, just last month, we opened the process. We opened the application portal to request non-public data by external entities. So we're very, very excited about that. And of course, as you mentioned, the size of California's population, the diversity of our population, the complexity of our healthcare marketplace, I think will make this database incredibly appealing. We also wanted to be a little forward looking. So we called our APCD the Healthcare Payments Database.
Yeah, why?
Let me tell you why. So we didn't include the payment. This is a little bit forward thinking, but really to just focus on just the prevalence of value-based care, managed care in the state, all of the non-claims payments that are occurring. We don't have those in the database now, but we are well on our way to establishing the rules that will be necessary and the specifications to collect those and add that to the database. And that's also building on some other work that's going on across the nation. So hopefully, maybe the HPD moniker will catch on for others.
So are we hoping like we're going to see a transition from APCDs to HPDs across the country?
We just really wanted to.
This is breaking news.
We're starting with claims. We're going to go beyond that, and so that's where HPD comes from.
Yeah, and California is kind of setting the pace for thinking about non-claims based payments. I know that there's a standard that's presently in development, and I think you've been working with OnPoint on that. Is that right?
Yes, we're working with OnPoint, other partners, National Association of Health Data Organizations, other states, health plans. It's really been an all-in effort. We want to make this something that we can adopt as a national standard, have the transparency around that, allow it to be updated and modified over time, and make sure folks have input. So I'm really excited about that piece. And again, for California to sort of give back, again, we've taken from those that have come before us and set us up for a good start. We want to give back, and we're trying to help be a convener and a leader in that space.
Yeah. So you're excited about this. Like Christoph's here. I see him in the off stage, and he's excited about this. And I'm excited about this. Like, who else should be excited about this? Like, who does this open doors for?
Well, we're just excited about how broad of use this may result in, right?
Yeah.
I mean, we see HCAI, and as I said, we've been doing healthcare data analysis for so long, serving a broad variety of users, if you will. So policymakers and the media and academic researchers and healthcare administrators and public health departments. So we really want data and evidence to inform all those audiences and as many stakeholder decisions as possible. We've been administering a hospital discharge database, as you know, for several decades, as other states do as well. There's one researcher at University of California that over a 2-decade period has published 60 peer-reviewed articles just from that one data set.
That's
incredible. They have a website where they list all that out.
Can we give him a shout out? Like,
well, I'll just say I'm thankful to them, and I'm thankful to all of our users, all of our researchers.
Yeah.
I sort of monitor the journals, and so again, with our discharge database, this is what we've been doing, kind of status quo. This isn't even looking at the claims data. We average somewhere between 2 to 3 new peer-reviewed research articles per month, so upwards of 30 per year. Now, I was just so excited, enamored with what folks can do with these data, and I think the HPD really just takes that to the next level and puts it all on steroids.
Yeah. So what should folks know about? I mean, because like it is, so to your point, like there's like the discharge data, and then like that's of a certain scale. But when you're talking about like an APCD or the HPD, I mean, that's it's a different orbit, right? I mean, like what should folks know about like when they're approaching an APCD based analysis?
So it's different orbit in several ways. And let me just say again, we come to this with tremendous humility, and we hope to learn as well from the research community, the user community. I have a research team. They're kicking the tires. They're getting their hands dirty with the data. But we think that the collective is really going to help us learn about the database as well. But with the discharge data, we collect something around 13 million encounters per year. In the HPD, it's upwards of 1 billion. So all of those claims. So just in terms of the volume, okay, you could try to get your mind around that part. It's all settings, so it's not just the hospital setting. So we're looking at outpatient, we're looking at labs, we're looking at pharmacy, that sort of thing. And then the key is cost. I mean, that's really the game changer. That's what we haven't been able to do, and all these research studies haven't been able to touch on with our data, but they will be able to now. Affordability, the costs of avoidable procedures, avoidable emergency department visits, reducing low value care, really helping purchasers to make better informed decisions and focusing on value. So we're just really excited for where this can all go.
Yeah. So are you most interested personally? I mean, like I know that like HCAI is going to consider a whole range of potential permitted applications for this data. Like if you had a twin who was going to work on some of these analyses, like what would that twin be like digging into?
Kevin, I don't even want to I want the chat. I want the audience that's listening to tell us. I mean, again, all these areas are of huge policy import. They're a huge importance administration to all Californians. I think we're in a period of healthcare reform. So knowing what reforms to make and where the most impact's going to be around affordability, around cost. I just think that's really the ticket and what to focus on.
Yeah. So like thinking about like so someone's interested, they see this video, they join you have a webinar coming up, right? Yes.
So we have a webinar. It's next Wednesday, January 15th from 2 to 3. So this is where my team, the staff, are going to walk through step by step the process of how to apply and be able to answer questions and things like that. So yeah, we encourage people to join in. But the application portal is live. You can create an account. You can fill out the form. There's obviously some steps to that. So we want to open up the doors and make sure we can answer folks' questions.
That's January 15th, 2 to 3 p.m. Pacific. Tune in, find more information on the HCAI HPD website. Yes. Yeah. So like the HPD website should have all of that information, and we can point people there. But like anything that folks should know about what information they should have to kind of fill out the application, or is there a cost involved?
Sure. Yeah, I'll note a couple things that folks should keep in mind. So number one, and this is sort of the framework that our statute, our laws are based on, and I think makes sense, is that all of the uses of the HPD must have a benefit to Californians. So keep that kind of end goal, that impact, what's going to be the result of this research. Keep that in mind when you're starting an application. That's number one. Number two, we follow the principle, and many are probably familiar with this, of minimum data necessary. So it's an important part of our privacy program. You'll be working collaboratively with my team to hammer that out. And so just to also to keep in mind about what type of data, what's the least minimum amount of data that's needed to answer your research or policy question. That's something that my team will want to know. Also, we have a public committee, the Data Release Committee, and there's more information about that committee on our website. They're responsible for reviewing some of the data requests that we process. So I'd suggest to folks to get familiar with that group, tune into their meeting, get a sense of who they are, what they might be looking for, questions they may ask. They may ask applicants. And yes, we do have a user fee structure in terms of cost to help sustain the operation infrastructure of the database. So you'll see the pricing schedule on our website. The purpose of this is so that we can scale the use of this database with demand, provide a good experience for all our users, but we want to lower the bar to access as much as possible and encourage as much use as possible as well.
Yeah, and it's access to 35 data for, I think I saw the stat, like 35 million.
Well, and that's an annualized figure.
Yeah.
I mean, we're really pushing 50 million when you talk about births and migrations and things like that. So I think we've even been surprised about the size of the population that's in the database.
And who's it? Who like so we have? I'm assuming it's a significant portion of the commercial market, including marketplace enrollees.
Yes.
The very important and interesting population to evaluate, especially in the coming years with lots of federal discussion. But also Medi-Cal enrollees are included in that, right?
That's right.
Okay. So if I'm a researcher, I know that a number of folks from Academy Health are planning on like looking at and viewing this video. I am always worried about whether I need to go through an IRB process. At what point does it reach the threshold of having to go through an IRB process versus just the data release?
So I'll encourage folks to tune into our webinar next week to make sure they get the specific details. But yes, certain data sets, identifiable data sets, do require IRB review, and we can help folks through that process as well.
Awesome. So, and if there are barriers, for some reason for cost, I think we have a partner who could potentially help, right? Right. And I'll bring him on. Christoph, it's so nice to see you.
Happy Friday.
I'm having way too much fun with these I haven't even explored all of the things I can do here. But Christoph, it's really nice to see you. Thank you for joining. You've been thinking about how to make access to health data possible for many years right now at the foundation, right?
We've been thinking about it. We've been cheering the state and Mike and his whole team on as they've embarked on this really important, very huge project. And we're just so excited to see where they're at, and so excited to be here in this moment. And so it's an exciting time.
Yeah. So tell me about the Affordability Fund.
The Affordability Fund is slightly less exciting than the launch of the HPD, but we still think it's a pretty big deal. It's something for folks that aren't aware. There's a lot of information available on our website. Certainly happy to follow up with anyone that has any questions about this afterwards. But the gist of this is it's $1 million. It's $1 million fund that we've set up. It's available to folks over the next, we'll make two kind of awards over the next we'll make two sets of awards over the next 2 years, totaling $1 million. To help offset some of the fees that you were just talking about with any data set, including this one. There are often fees associated, and so we need to offset or want to help offset those. And some of this fund is also available to offset some research time. So we often partner in our work with folks in university settings or other research institutions, and they need money in order to offset the cost of their time to do the research. And so this is a way that, or a fund that we've set up to help folks get access to this data, and then use it to tell us all sorts of interesting things about the healthcare system here in California.
What inspired it? Like, when did the idea come up? And like,
I don't know when it exactly came up, but it's certainly something we've been thinking about. We've been getting more and more excited as we've kind of built to this moment here. Mike talked about just the years of work that he and his team have put in to get us to this moment, and here we are. The research portal is open. They're open for business. It's ready. And so as we got sort of closer and closer to that, we were thinking through how do we really do what we can to try to increase access to this data, because it's such a rich new data source. There are so many things we don't know about our healthcare system here in California. There are so many things we'd like to know, specifically related to costs and affordability, and some new state authority that's available here in California. And so what do we do? What can we do to help find some answers to those questions, or help people do important research? And this was a way. Let's help make it more affordable for folks to do this type of research, and cover their time.
So I want to come back and ask, like, if you rule the world, and like you like, what would you dig into? But like Mike, like, how do you see like the release of the HPD and like the market reasonable prices, like, and this new California fund kind of playing together to make sure that everyone has access to this data if they really need it for good purposes?
Well, it's a great question. I mean, I think we're interested in maximizing use as much as possible. I will say we're going to be gauging demand, and that's been something we've struggled to predict to some degree, because of all the reasons we said of how are we big? Are we a big box store? I mean, we're going to have a lot of customers, and just so zeroing in kind of the capacity that we're going to need behind the scenes, again, to make that a good customer experience, to deliver data, to deliver the analytic tools we need in an appropriate way, and to not sort of crowd out the different types of users. So that's one component of it. Again, we have our pricing schedule. We'll revise that over time. Again, our goal is to lower the barrier as much as possible, but this is how we're going to start out. And so I really think that this funding opportunity, again, with great gratitude and just thanks to the California Healthcare Foundation and Christoph for his leadership in this area, just helps offset that a bit and give some folks a leg up and some seed money and just to get us kicked off with this thing. Yeah.
So Christoph, if you were going to have folks kind of focus on one type of question, like that's really keeping you up at night, and knowing that it's not the scope of what the grant funding is available for, but like what's really of interest to you?
So is this
what type of live stream would you tune into to hear the results?
Am I answering this as king of the world, or is this
you are answering this as king of the world?
Well, there's I would be an unfocused, definitely an unfocused ruler. I think there are definitely more interesting than uninteresting things and research questions in the world, and so I think this is a pretty broad call for folks that are interested in doing research into affordability challenges that consumers are facing, and importantly, the system-wide drivers beneath those affordability challenges. Yeah. And so I'll get to some specific, I'll just throw out some illustrative kind of questions and things that are interesting. But before I do that, I do want to say that, within the claims and encounter data that you did such a nice job laying out, there's not a ton, but there is some information there around consumer cost burden. And we've had different data sources that we've used to triangulate, what's going on here in California. Unfortunately, that's not a great story. We know we're in the midst of what is really an affordability crisis. I think one of the data points that really sticks in my mind is when we survey folks broadly within the state, 1 out of 2 Californians has some sort of cost-related access challenge within the last year. That is really it's always shocking, even to every time I hear it. But there is some data, we have other data points on that, but this is really in sort of the member files and in the claims. Like, there is new information here to understand how much is that, what is that burden, where does that burden come from? And so I think a set of questions, or sort of research questions around specific consumer cost burden issues, would be particularly interesting. We've issued a broad call for that.
Yeah.
Now, I'm going to talk about it second, but I think it's equally or as important. And I think here claims and encounter data can actually tell us a little bit more. And that's around these systemic cost drivers. And so there's all sorts of general questions that I think would be helpful because, again, we've able to triangulate this from different data sources around spending growth sort of overall and for whom and why is spending growing. Like those types of questions, like claims and encounter data, is great for, particularly a data set of this size.
Yeah.
And then there starts to be more specific questions around like excess or unnecessary or wasteful spending, or ways that people think that, or ways people have called it. Mike alluded to this a little bit around like, unnecessary spending or
low value care.
Low value care. What do we know about that, in this data? Where is it coming from? What seems to be driving it? Is it associated? These start to be academic sort of like research questions around association with certain geographic areas or particular systems or particular health insurance types or for particular conditions. Like those types of questions, when you've got, like a dependent variable around excess spending, and then you've got all sorts of independent variables that you can test the associations with. I think that would be particularly interesting. And then the last thing I'll say, and then I'll shut up. I'll shut up a bit here.
You're king of the world, so I mean,
exactly. So I get to keep talking. I would say the last thing to just know is we are very interested here in work that is policy relevant, and there are all sorts of there's all sorts of activity at the state level right now around healthcare costs. So I can throw out a few areas around like ownership type, for instance, particular private equity. How does that impact costs and utilization trends, which bear on spending? That certainly was relevant in the last couple of years, and I would imagine is going to remain relevant over the next few. PCP and our primary care, having a primary care provider designated to you, being associated with a patient-centered medical home, like that's in the member eligibility files that Mike and his team are collecting. How does that associate with spending and utilization trends? Pharmacy claims. Pharmacy is a huge area for us. There's a lot, there's been a lot of work at the state level on pharmacy. There's lots to unpack there. Site of service and implication for spending. Like I could go on and on and on. Yeah. But I think the important point here is that work that is telling us something about spending and spending drivers within the system is linked to some very policy relevant area at the state level would be of particular interest to all of us.
And I know this is an area where a number of APCDs continue to mature their capabilities. And I will end like in a couple minutes with like the last question of like, what's on your 2025 data wish list? Like, what would you love to see done, or where would you like to be in at the end of the year? But Mike, like when we're thinking about the HPD and pharmacy data and provider data, I know that HCAI is doing a tremendous amount of work behind the scenes to build capacity and understand transparency in each of these areas. What should folks like expect just from APD or HPD version 1 that they get versus what they might expect going forward?
Sure. Well, as mentioned, we do want to add data sets, add data elements, add new things to the database. So we're working on that actually in a number of different areas. So the contents of the database now are routine and are all the areas that Christoph described and what are described in the NADO APCD common data layout, but non-claims is huge. I mean, that's going to be a big focus for us. That's going to include the pharmacy side as well. We're also working to add dental claims to the database, so we're working through that. We have a outreach plan to encourage ERISA data submission as well. So I think there's going to be a lot of areas we're going to keep seeing new contents of the database become available for request. And then my team's also producing reports and analyses. So we have a public reporting agenda, public reporting plan. This is something that we create together with stakeholders, with our stakeholder committee, and we posted that publicly. So we have a series of reports that we plan to release also beginning of this year that we hope are informative on their own and maybe spark ideas amongst the research community for how they can dig deeper on it as well.
Will you be releasing code with the reports?
I think that is a great idea, Kevin. So let me say one thing. I don't know that a lot of the folks do this. We publish an open data set of every report that we release. So we release interactive online visualizations. We use Tableau, so it's a point and click kind of GUI where you can do simple query and analysis. The underlying de-identified data set for each of those reports, we publish in an open data set that's API enabled. So we go as far as we can in terms of data transparency. You can reproduce our work. We show our work. You can reproduce our analyses in your own tools. That's kind of maybe step one. I love what you're suggesting, which is the analytic code behind that analysis. How can we put that into a common space? I think this actually gets more on the non-public data release. And we're working with researchers and others. Can we share code? Can we share notes? Can we share things we're finding in the data and open source some of that? I think that is a really great area of opportunity that I'd love to explore.
Yeah, so I look forward to that. I mean, it sounds like California really is setting the pace for what to put out, really kind of reflecting on what's previously worked in the field, and Office of Healthcare Affordability. Like Christoph, you mentioned, identifying cost drivers, identifying changing consumer cost burden, opportunities for reducing administrative waste. I think that those are all, like Mike, I think issues that Office of Healthcare Affordability is thinking about and might be in some of these reports. But I think it could really be incredibly interesting to see this new world of information about how our healthcare system is operating and how we're paying for it come out there. But I have one more question for you guys. So, like 2025, we just started off the year. I'm looking forward to moving on from my current phase of parental leave, although I treasure it dearly. But like to do so much of the work that we love to do. Like what is on your 2025 list when it comes to seeing like health data capacity build, like empowering folks to use this data and translate it into information and translate it into change? Christoph, I'll start with you, and then Mike, and we'll close from there, because yeah,
I think specifically related to this data set, again, we're really excited about it. If I had a wish list here or for additional information, I think we'll all know a little bit more this time next year about what some of the potential and limitations are of this data. So any data set I've ever seen or used, there are data quality and completeness issues. I know they've done just a heroic job over at HCAI to get this prepared and get it ready. And I know there's a lot that they've done. And I think, a lot of the early questions that we're getting from folks that are interested in this research fund are related to the data, and they're like, what's in there? How much is missing? Where, can we use all of it? And, we're referring all of them over to HCAI, and I think there is some information there, but I think we'll know a lot more in a year's time. And I think that that's helpful, because any data set that gets used, I think gets better with time. So let's take this as sort of here's our first year and folks are starting to use it. We're going to find out what we can use it for and where we need to do some work. There's been a lot of work over the last few years around encounter data improvement, in particular in the Medi-Cal program. We know that there are data quality and completeness issues there. And so, is that going to come up? Probably. And what can we do about it to improve this data? And so I would put that number one sort of on my wish list, is more information. Not that it means it's bad data. It's just, what do we do to make it better? I think that would be a wish list item. And then maybe the second one is, this time next year, we've got a whole bunch of researchers doing really impactful work, maybe some of whom this is their first big research project, or they're earlier in their career. They happen to be from a demographic group that's underrepresented in the health services research community. We know there are folks that traditionally haven't been able to participate, and cost is a barrier for some of them. And I hope that this research fund and other state foundations or other funding sources are doing work to really democratize access to this data. Look, access to data costs money, and we're here to try to do what we can to offset that.
I'm pulling that quote out, and I'm just going to share it everywhere. Everyone, I mean, this is, as I see investments in so many of these private claims databases, I think it only furthers the information inequities we have in our healthcare system. I really applaud all the work that you're doing here.
Yeah, data do cost money, and running a data, there is this, Mike can probably talk, there's a requirement that this be, there are different funding sources in order to make this work. And so certainly, it's not unusual to have data fees. And as you mentioned, some of these private, much more limited data sets are quite expensive.
Very expensive. And sometimes that expense is subjective depending upon the project you're working on, not speaking from personal experience or anything. But you in your first kind of wish list item, like getting the data into hands of people that can use it, letting them start to use it, and then have secondly, a learning system to start to continue to improve the data, which is an amazing first year goal. Mike, what do you think? 2025 wish list.
I mean, Christoph, I think put it perfectly. I'll touch on a couple of things. I mean, on the investment piece, I mean, it's a public resource, and public resources need continuous investment. And I think that applies to healthcare data infrastructure more broadly. So we built the Golden Gate Bridge. If you drive over it, you pay a use fee. That helps keep it maintained. And I think again, across the board, more investment in healthcare data infrastructure is necessary. On the learning, again, we come to this with tremendous humility. The discharge database I mentioned. So we first started collecting inpatient discharges in the 1980s, and we added emergency department encounters in the early 2000s. So here we are, fast forward 40 or more years later, and it's the gold standard in terms of data quality and completeness. So I promise the HPD is not going to take decades to become the gold standard, but just as Christoph said, we're going to know so much more than we do today in a year from now. And so putting the data out there, getting it used, it's really the use that's going to inform that. So I'm just really, really excited about where we are, and just all the partners and all the friends we've made along the way.
Yeah. Well, for my end, I am thankful to have you guys as leaders in this space. Mike, I mean, you are really, it's just, we've known each other for a while, and it's just been amazing to see how HCAI and its health data capabilities have grown along with you as CIO of HCAI, and it is remarkable. And California is a pace setter in so many ways. And I know it's not just you, and you have a team and leadership, but all due credit. It's been remarkable to see that growth, and I think this is a real milestone. And I hope you're as proud of it as I think so many of us are as excited about it. And Christoph, thank you for making this investment in health information equity. It's something that's not on most folks' radars, but if we are going to create a more equitable healthcare system, I think we need to have equitable information about how that healthcare system is working and for whom. So I want to thank you both. This is my first live stream. It might be my last live stream, but I am glad that I was here with you guys. I also know that we have some questions from LinkedIn, which we're not seeing because I don't know why. So I may share those offline and we can get responses to folks. But with that, I'm going to end the stream and thank you both. Have a great weekend to you guys and to all who are listening.
Thanks, Kevin. Thank you for having me.
Bye.
Be well.